Patient has 3 herniated discs, L3-4, L4-5, and L5-S1. We're going to be going on the left side because that's where their pain is. All right, let me know if it's uncomfortable and I will give you more numbing medicine, okay? You just say ouch if it's bothering you and I'll go ahead and give you more numbing medicine. All right, deal? All right. Shot. I'm going to be talking to my team as we're going along. Local. So I'm going to be asking them to do a shot. A shot just means take a picture, okay? And we're going to put you to sleep just as soon as we can. That's a little more a little more numbing medicine going in. Shot. Okay, very good. Well, we're going to start with the L5-S1 disc. Just relax. Everything is going great, okay? I'll let you know if we're having any kind of problem. I don't expect any issues. Shot. Shot. Very nice. Shot. Let me know if you're having any pain. Shot. Shot. AP. So you can see we're entering the foramen at L5-S1 on the left. We're just at the anterior border of the S1 superior facet. It's perfect positioning. She's doing great. She's making my job much easier by laying still. You can actually see she's got a little bit of sacral spinal bifida on the left. We're just commenting your lamina didn't fuse properly as a fetus in utero, and we see that a lot. Nothing to worry about. You don't need it treated. Are you okay? Yeah? Yes. All right. No leg pain, correct? Okay. A big tear there. Went in easy. I think we're good. So the hardest one to access we've just done. We're going to go for the easier ones now. Let me know if you're uncomfortable, okay? Everything's going perfect, by the way. Shot. We're going to go for the L4-5 next. Shot. So the first step in all these surgeries is to gain access to the annular tear herniation through a transforaminal endoscopic approach. And that's what we're doing right now. Shot. Just going right past her facet. Shot. All right, entering the foramen, we'll get an AP view. AP means anterior, posterior, front, back. We want to use 2 views at a minimum, lateral and AP, sometimes oblique, but we never really use the oblique here. Perfect. Again, she's wonderful. She's not moving around. She's making this, you know, really, really good for the surgeon and herself. Any pain? Are you there? Is she awake? Are you awake? I'm happy you're dozing off. All right. We'll need her awake in just a few minutes. Shot. Yeah. I'm not terribly concerned about a nerve root injury because she's got such a nice anatomy that shot. I'm going way below the nerve root, like nowhere near it. Shot. Shot. All right. Shot. Shot. I need her awake in about a minute. Shot. Shot. All right. Are you okay? Yeah. No leg pain, right?
No.
Give me an AP. Any other sensations, feelings? Gosh, looks really good. All right. Well, this is going to be for you. You can go back and watch what you had done. So our patient has 3 herniated discs, L3-4, L4-5, L5-S1. Just because she has 3 herniated discs doesn't mean they're all causing her pain. But when I asked her on exam, where is your back pain? She showed me it's right in here. Okay? And I also have it here and here. So I knew that where she was pointing was the L3-4 disc, the L4-5 disc, and the L5-S1 disc. Plus she was pointing at the L5-S1 facet joint on both sides. And when I started pushing on the facet joints in the clinic, it hurt her. So I knew she had inflammation there. Are you awake? So the question is, how much discomfort is there at each of these discs? No, we don't want to tell her that. Are you comfortable? All right. Now, how long have you had back pain for? How many years? I couldn't hear.
6.
So before 6 years, you were fine.
Yes.
Is that correct? So 6 years. And how long have you had leg symptoms? Left lower extremity. How many years your left leg?
6.
6 years. So her back and leg started about the same time. Are you comfortable? Alrighty. How bad is that on a scale of 1 to 10?
10. 7.
7. That's the worst it got, was a 7? Yes? All right. Is that where you typically get pain? All right. I couldn't even get enough pressure in the disc because it just, you see how big the tear is? It just leaked out. So that was a 7/10 at L5-S1 concordant. All right. Is it eased off at all? Okay. You have a huge tear down there at L5-S1. When you look at the MRI, it doesn't look that bad. A lot of doctors would not treat L5-S1, but definitely it's causing her pain. How bad is that on a scale of 1 to 10? 9. Is that where you typically get back pain? Good job. You're so, my God, I wish all my patients were like you. All right. Well, you probably guessed it. We're at the last one. Are you feeling better? Sure. She says sure.
Yes.
How bad is that on a scale of 1 to 10? 10. She said 10, right? Is that where you get back pain? We're going to have all 3 of those discs fixed for you when you wake up, and you won't have that pain anymore the rest of your life. All right. Give me a count from 1 to 100 out loud, okay? I need you to count in Swedish. Count out loud for me. What other languages do you speak? I didn't hear her. Finnish. All right, count in Finnish. All right, keep counting. You're doing great. All right, so the reason we have our patients count out loud is so that we can know when they go to sleep, basically. Because when they go to sleep, they stop counting. So it's a wonderful technique that I learned from my past mentor, Dr. Albert Roten. He taught that to me because he did a lot of procedures under Brevitol. You know, it was back before propofol was available. And he would do a radio frequency rhizotomy of the trigeminal nerve, Gasserian ganglion, and he wanted to know when the patient was asleep because that thing hurt like heck. So he'd have the patient count. The anesthesiologist would use Brevitol, put the patient to sleep, and he would then rhizotomize. Let's show the dye in the epidural space. It leaked out from these giant tears, annular tears. There it is. Now show the dye running down that S1 nerve root. There it is. Look at that. Pretty cool, huh? All right, here we go. We're going to start with the L5-S1 shot. We're bringing the dilator down. We're going to be just to the side of the nerve, just below it and to the side of it. Shot. All right. So far, so good. She's asleep. She's comfortable. She's in her happy place. When she wakes up, we'll be done with the surgery, hopefully. Shot. Perfect. Shot. Yeah. Let's see, shot. So we're inside the tear. Go ahead and remove that. All right. This is the L5-S1. So, Henry, do you mind showing the audience why do people with annular tears in the back of their disc, why do they get back pain? We discovered this at Deuk Spine Institute, and we've been trying to teach people about it for years. Are we in there? I can't really tell. I think almost. Whoops, sorry, Luis. Oh my God. All right, that's good. I think Luis is going to get a shot at me at the end of the case. All right, Henry, can you run the video?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We have just entered the L5-S1 disc, and what do we see here? The herniation. The blue dye is staining degenerated nucleus pulposus. That is the jelly from the center of the disc that is now degenerated. It's degenerated because of inflammation. What causes the inflammation? The jelly. Where does the inflammation occur? In the back of the disc, in the tear. So it's actually the inflammation from the annular tear attacking the jelly that's trying to escape. And that's where all the back pain comes from. It's also where the leg pain comes from. Thank you, Oscar. So this is our last surgery for today. We've already done 4. This is our 5th case, and busy day today. But very happy patients. Everyone is heading home, and this is our last one. She'll go home as well. I think her husband is picking her up after the surgery. Now she's going to have 3 discs repaired, L3-4, 4-5-5-1. She's also going to have the Deuk plasma rhizotomy done at L5-S1. What is the Deuk plasma rhizotomy? We keep talking about it. Well, it's a new way to do a rhizotomy. Why do people need rhizotomy? Well, rhizotomy is quite honestly the best treatment for pain that comes from a facet joint. What is a facet joint? It's a small joint in the back of the spine that causes pain in about 15% of the time, it's the cause of back pain. It's not as common as a herniated disc pain, but it is pretty common. We do see a lot of it. Sometimes we don't even know patients have it until after they have their disc fixed with the Deuk laser disc repair. And then we got to bring them back and do a rhizotomy. Now, what's the difference between a Deuk plasma rhizotomy and other rhizotomies that are done out there? The answer is the Deuk plasma rhizotomy works better. And the reason it works better is when I show you guys how it's done in the near future, you'll understand. But it's more energy being delivered. Plus, I'm able to move the tip of our probe, unlike an RFA probe, which can't be moved. It just stays in one place. Because of those two features, it allows me to have more control over where we're deadening the pain nerve that goes to the facet joint. It's a quick procedure, but it's done with an incision, so it's a surgical procedure. You can see the blue dye escaping from the disc. Any questions from our audience?
No current questions.
Let's show people what does the Deuk laser disc repair actually do? Why is it unique? Watch this video and you'll see the purpose of the Deuk laser disc repair is to debride the annular tear by removing the herniation from inside the annular tear. It's very different than most traditional spine surgeries that are focused on just removing part of the herniation sticking out, pushing against the nerve. We're actually going for the part of the herniation that doesn't stick out. So it is different, and the whole purpose is to cure back pain or neck pain that's associated with an annular tear and a herniation. By the way, I'm working on the annular tear right now as we're watching. That's what the laser fiber is zapping, is the herniated disc inside the annular tear. Go ahead and show the video so people can understand what we're doing.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, hopefully the video has helped you better understand how the Deuk laser disc repair works to eliminate pain that's originating from a herniated disc, specifically from a tear in the back of the herniated disc. The same tear from which the herniation comes out. The herniation is actually the nucleus pulposus, the jelly that should be in the middle of your disc, is pushing out through a breach in the wall of the disc. It's kind of like an escaping tissue moving through the annular tear. And as it does that, it sets up an inflammation process within that annulus, and that inflammation is your body attacking the escaping nucleus. And as your body attacks it, it's trying to get rid of it and eliminate it. Kind of like how your body would attack a splinter in your finger. Of course, it's easy to think of why your body would attack a splinter, right? A splinter is a foreign body. We call it a foreign body. Foreign body is anything that your body doesn't recognize as its own, as itself. I don't mean immunologically recognized, I just mean physically recognize or chemically recognize. So when your body encounters something it considers to be an invader, a foreign invader, it attacks it properly, right? And it attacks it with a humoral mediated system called the inflammatory system, or inflammation. And inflammation is basically a process whereby your body sends more blood flow to that area. So you get hyperemia, which is increased blood flow to that area. You also get swelling, tenderness and pain, and of course the increased blood flow brings a higher temperature as well. So inflammation brings heat. So you're going to have painful, swollen, hot and tender area in your disc, and that's what people are feeling. Okay? That's the inflammation going on in their disc, and that's what we're here to remove, is the source of inflammation. Yeah, she's a little light. Yeah, she's complaining a little bit, which understandably so. Yeah, I'll just wait. You're giving her a little bolus. Tell me when. You can see part of the tear. Hold this right here, Luis.
Yes, sir. Okay.
This is fat, but I think we're pretty much done here. So that fat is around the nerve root. Let me see a grabber. Just want to make sure we're not leaving anything behind. The L5-S1 had a big tear, but it didn't have a big herniation. So you can see the tear right there. Oh yeah, there's a little piece of herniation. There's another piece. Hold the tube.
Yep.
Thanks, Luis. So if you look at the MRI, you can actually see at L5-S1, oh yeah, there's another piece. The herniation is literally stuck inside the tear. It hasn't escaped, into the epidural space. Gosh, this is it. Very good. She's going to feel a lot better when this is all done. Oh yeah, hold it. Just little pieces. These pieces, they look big on the endoscope, but in real life, they're about 2 millimeters each. That's about it. All right, we're done with this disc.
Lights on, please. Thank you.
Scope off. So yeah, those pieces, I'll show them to you right here. You see this? And Henry, you see it?
Yes, we see it.
Just right here is a few of the pieces. They're very small, but they're in just the right spot to cause so much pain through the inflammation I was talking about. Right now we've put a little antiseptic in, which is called betadine, developed by NASA not far away from here for dealing with alien life forms. And it's actually quite effective at killing all microorganisms, viruses, bacteria, fungus, and protozoans. Not that we expect there to be any of that down here. Please don't take that the wrong way, but it's standard in surgery to use a little antiseptic whenever you do a surgical procedure to cleanse the wound, just in case somehow a piece of dust got down there with some bacteria on it. I know it seems kind of crazy, but we always take extra precautions. After all, these are human beings, and God forbid they get an infection. It can be a really bad day for them. So we want to make sure we take every possible precaution, and then some. That's reasonable, of course. So she gets a little betadine down there. Betadine is iodine based, and iodine is actually quite bactericidal and fungicidal, protocidal, virucidal, and the right concentration. Okay, we've finished the L5-S1. We're going to move on to the L4-5 next. She's got a good size herniation there. Shot. Great. I'm going to take this needle out and leave the guide wire.
Seating off, please. Thank you.
We have a question.
All right, just take a look at the dilator. This is what we're going to slide down the guide wire. This is going to spread the tissues open just enough to make a little window for the tube to go in. Yes, Shot, I'll take the question.
This question comes from Shalise on Facebook.
Shalise, you're still with us. Nice. Great, absolutely. So happy to have you still with us.
They responded, or they asked, I've been with you for all your surgeries today.
Wonderful.
Thank you for letting me tag along. Question, do you not fix the part of the disc pushing the nerve? I'm confused.
Oh no, we fixed the part of the disc pushing the nerve, absolutely. As a matter of fact, as you're about to see, right about now, I'm about to touch the part of the disc herniation that's pushing on the nerve. You see that curve in front of me? That is the dye behind the herniation, but that shadow, that area that's white is actually the herniation. I'm going to push that herniation back in right now, inside the disc, and then I'm going to go fish it out. Shot? And that is a wonderful way to do this. It was taught to me by Dr. Young, Anthony Young. It's called the inside out technique. Shot? So the Deuk laser disc repair is actually a combination of different techniques. And the part that's unique to the Deuk laser disc repair is the annular debridement. Everything else I pretty much learned from other spine surgeons that had been doing endoscopic surgery before me. But the annular debridement is actually the most important part of the surgery. They didn't discover it, I did. And as a result, we published it 10 years ago, and we've been doing it for 16 years this way. But you can just see what I did. I literally shoved the herniation back into the disc through the tear. And now I'm going to use a laser and grabber to remove the herniation that was outside of the disc. The truth is, most herniations are bulges, which are not true extrusions. I must be upset with you, Luis.
Come on,
I don't know why.
twice.
That's twice I hit you. Gonna have to let Luis get a few hits on me. I owe him. I've hit his hand with the hammer twice now. I think my contact's floating around in my eye a little bit. I need to see
Nice on, please.
just for a second. I can't really see. There it is. Okay. So I don't know. Hopefully that answers your question. So we are removing not just the part of the herniation stuck in the tear, but also the part that was sticking out. That's why at the end I look around in the foramen and I didn't see any herniation there. Okay? So we make sure we remove it all.
Shalise commented, and she said, oh, now I understand.
Yeah. Yep. These are all parts of the herniation right here, the blue stuff. Remember, there should be no blue in a normal disc. When we do a discogram, you won't see any blue if the disc is normal. But when you have a herniated disc, degenerated disc, you're going to get blue stain. It's always abnormal. The reason is the blue stain is it binds to disc material that's acidic, not Hasidic, like Hasidic Jews. Acidic, as in the pH is below 7.4, which is neutral. So this blue dye will stain to any tissue, disc tissue, when its pH is below, like, I don't know exactly what the pH has to be, but let's just say it's acidic. Okay? So it's probably somewhere around 7.0 or below. Maybe 6.5 or 5.5. I don't know how acidic the disc has to be.
2 minutes and then turn on.
But it has to be acidic. Not basic, but acidic. All right? All right. Do you have another question for me?
Yes. This next question comes from Lizzie Henry on Facebook.
Hi there. Welcome to our live stream of spine surgery on October 11th, 2022, the day before my wedding anniversary.
Congratulations.
Thank you.
And with Lizzie's question, she asked, what goes back in the disc and how does, what goes back in the disc and how does, what if anything stay in there since the disc is torn?
Yeah, great question. We're not taking the disc out. We're only taking the herniation out. The herniation used to be in the middle of the disc, but it's no longer in the middle of the disc. It's a piece of the middle that shot out through the tear, usually more than one piece to be exact. Normally it's going to be around 20 pieces of the middle that shot out. So we're not taking any of the normal disc out with this surgery. We're taking the herniations out and we're cleaning the tear with a laser. So we're not putting anything back either. People have tried putting stuff in the disc for years, and none of it has ever been approved by the FDA. Do you know why? Because it doesn't work. There's lots of people that are trying to get rich off of making something that sticks inside the disc to replace this jelly that's gone. But none of it works. It always ends up being pushed out after a few weeks. Whatever they put in there comes back out. The only way to keep it in there is to do an artificial disc or to fuse. So there's no movement at all. But it's the loading of that disc by the pressure of the weight of your body that will literally push whatever you stick in there back out. So people have tried for years to develop things to put in the disc so they can sell that to you. But none of it has ever worked. And everything they put in comes out. And when it comes out and hits the nerves and causes the person to be paralyzed. So that's why the FDA has never approved any of that technology. People have been trying to develop disc materials to go into the disc for 20 years, ever since I was a neurosurgeon, maybe before that. And the best they came up with is artificial discs. But you know, artificial discs don't work well. They end up popping out. They end up failing. They don't really do much of what they're supposed to do. There's a piece of herniation right there.
We have another question.
Yep, I'm happy to take it.
This comes from Dr. Dalip on YouTube.
Hello, doctor.
They asked, I am a endoscopic spine surgeon from India. It's a great technique, sir. Do you also do trans-Cambens fusions under local or prefer interlaminar?
I didn't hear. What kind of fusions?
Do you also do trans-Cambens fusion?
Oh, transforaminal fusion.
Yeah, transforaminal fusions under local or prefer interlaminar?
Yeah, great question. So I actually did the first transforaminal fusion in the United States 12 years ago, almost 13 years ago. Endoscopic, transforaminal, endoscopic, using this particular endoscopic system. And I used the sac filled with bone graft. And the surgery went fine, but the reality is there's no need for fusion, doctor. There's no need to do a fusion. With my technique, you don't need to fuse, no matter how degenerated the disc is. Whether or not there's spondylolisthesis, scoliosis, none of that matters. If you do this technique for a herniated disc, and if you treat the right discs, plural, then you will not need to do a fusion. But can we do a fusion? Absolutely. Have I done this transforaminal fusion before? Yes. Yep. It's just not necessary. There's no reason to do the fusion except to make more money. And I don't believe in doing procedures on people that are unnecessary to make more money. So I don't know if that answers your question. I can do it, I don't do it because it's not necessary.
We have 2 more questions.
Uh-huh.
This next one comes from Mustafa on YouTube. And they asked, what is the advantage to go for laser disc repair instead of ADR?
Oh, well, great question. So ADR is anterior or artificial disc replacement, ADR, artificial disc replacement. And what you're doing with the artificial disc is you're taking the patient's natural disc out, removing it completely, using tools, metal tools that scrape away the disc. Then you're putting a metal and plastic substitute disc in there. Why am I getting so much air bubbles here? I'm sorry? There shouldn't be this much air bubbles. Okay? Whatever you're doing is doing something to create more air bubbles. I don't like it. Huh? Then why are we using it? Why? This is not the time to experiment with new things. All right, so artificial disc replacement, the surgeon is removing the entire disc and putting a metal and plastic disc there. The problem with that procedure is it's unnecessary. You don't need to do that. We're repairing the disc the patient already has. We're not taking their disc out. We're just fixing the tear in the back of the disc, called the annular tear, and the herniation. But we're not taking their natural disc away. We're keeping it. It's always better to keep your natural disc than to try to put an artificial disc there. I don't recommend artificial discs to anybody. I was part of the medical team, surgical team that put the artificial discs in the United States back in early 2000s. We were doing the FDA trials. The artificial discs were being put in at several different institutions, and University of Florida in Gainesville was one of those institutions. That's where I did my training in neurosurgery. And we were a center or a site for the FDA trials for artificial discs. And of course, I was part of that whole process. I have information about it. What I've always found is that the artificial disc company manufacturers and distributors will lie about the results of the artificial disc. They make up information that isn't true, and they do it because they want to sell those artificial discs to patients and doctors. They want surgeons to put them in. They want surgeons to believe that they're better than, say, fusion, when they're really not. Okay? So I never believed in the artificial disc technology. We tried putting them in as part of the FDA ID study site. I've watched patients that have had them done over the years. They do terrible. Patients have all kinds of problems. And they published a paper recently showing that people who get artificial discs end up having the same rate of adjacent segment disease as fusions. There's no difference between the two groups of patients. Artificial disc versus fusion. Now, my patients have no adjacent segment disease. People don't ever come back with adjacent segment disease because we're not altering the biomechanics of their natural disc in any way, as you would do with a fusion or artificial disc. Hey guys, what's going on? It's sucking the air in through wherever you stab through the bag, if there's a bigger opening. You understand? there's a pump, right? And the pump, it sucks. Does it push the
Yes.
the bag?
Yes.
All right. I'm not sure where the air bubbles would be coming from then, but we're having them, and I don't like it. What about using a regular bag that we normally use? We're just about done with this disc.
Hey, you want to use a manual one bag? Okay. Gotcha. Thank you.
See how the laser was able to take care of the bleeding right there? Pretty cool, huh?
We have a couple more questions.
I'll take the questions.
All right, this first one comes from Shalise on Facebook.
Hi again.
They asked, how soon after surgery can I fly back to Utah?
How soon after this type of surgery can you fly back to Utah? You can fly the next day. All of our patients that travel here from other countries or other states, they all fly home the next day. I mean, unless they want to stay here, of course, but not for medical reasons, just for, they want to go to the beach or they want to go to Orlando to see, you know, Disney with their families, or they want to go to, you know, Kennedy Space Center or go on a cruise afterwards right here out of the port. So we get people who come here and they really enjoy being here for other than having their back or neck fixed, and they just do some tourism. Maybe they go down to Miami, over to Tampa, Pensacola, Tallahassee, Georgia. Point is, you can leave the next day to go home, or you could stick around. But if you stick around, don't do it on my account. Do it because you wanna check the area out. Where are you in Utah? All right. Well, while they're writing their answer, let's take the next question.
Next question comes from Lizzie Henry, once more on Facebook. And they ask, how does the disc heal and not have another rupture?
That's a great question. So how does the disc heal and not have another rupture? So just to get an idea, that's a piece of herniation. This tube you're seeing side to side is 6 millimeters. 6 millimeters is not big. So it's very easy to heal. It just looks like a big area that needs to heal. That's because we're so magnified, we're seeing everything zoomed up. But it's really a very small area that needs to heal. The problem is that the discs don't have much blood supply. So they heal, another piece of herniation going out. They heal slow. And we tell people that their disc will be healed in a year, and that they should take it easy for a year. So the way you prevent another herniation is by not bending over at the waist. So we give a 3-month restriction on bending at the waist, and then of course not lifting anything heavy. Okay, so you're going to have a 25-pound lifting restriction for the first 6 weeks, and then that goes to 40 pounds. So it's basically just restrictions that keep the disc from reherniating. That's all you need to do. It works great if you just follow those restrictions. And the disc definitely heals. Your body has great ability to heal things. The only reason the disc was not able to heal was because it had the jelly stuck in it. Let's just run that video one more time so everybody can see how annular tear and herniation causes so much problems. It's really your body trying to heal it that causes all the inflammation and pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, we've just completed our second disc, Deuk laser disc repair, and debridement of the annular tear and removal of the herniation, both within the tear and outside. And I looked around at the end, I didn't see any herniation near the nerve root anymore. So very happy with that. We've had some great questions, and I just showed you another animation that explains how that tear forms, and then shortly afterwards, just by normal activity, you can push herniated nucleus from inside the disc out through the tear. It gets stuck in there and causes lots of inflammation, and that inflammation is where all the pain comes from. Okay? So what's wrong? All right, let's come into a lateral view. So really it's the jelly, the nucleus pulposus jelly stuck in the tear that creates all the problems for patients. And when I go in there with the laser, I clean that jelly out of there. I'm not taking the disc out. We're leaving her disc alone. The only thing I'm taking out is the jelly that's stuck in the tear and the jelly that's outside of the tear pushing on the nerve root. All right. We're going to be doing the L3-4 next. The L3-4 is the third and final disc needed to be repaired here. We're doing it all through the same incision, a 1/4 inch incision. Shot. Patient's doing quite well. How's she doing, doctor? Anesthesiologist says she's excellent. We're going to go into the last disc. We're going right through the herniation and tear. That's the beauty of this technique. This was developed by, the approach was developed by Dr. Parvis Kambin, this transforaminal approach. But going into the tear first was developed by Dr. Young, Anthony Young, called the inside out technique. Hold on, yeah, I think that's good. The reason why the spine is so hazy is there's just a lot of contrast material kind of spilled out everywhere, so it's radio opaque. Lay still, you're doing great. Are you giving her a little bit more? Good. All right. I could give her a little more numbing maybe in the disc. What do you think? Oh, that's the irrigation. All right, all right. Just relax, you're doing great. Take that out. I'm going to try to make her a little more comfortable by numbing up the disc a little bit more.
We have a few more questions.
Sure, we'll take them.
This next one comes from Shalise once more.
How are you doing, Doc? Should I wait? Shot? Yes, Shalise?
Yes, Shalise. She is 30 minutes north of Salt Lake City, Syracuse. And her question is, yeah, my doctors are saying pain is coming from L4 through L5 bulge, but I feel like it's lower L5-S1, which shows some bulge also. They are strictly off the MRI. Is that something you would be able to tell from an MRI, or would you have to have an examination show more? Is the bigger bulge always the source of pain?
Hey, great question. Thank you for asking it. The answer is I cannot, and nobody can tell from an MRI alone. Anyone who tells you from an MRI alone what's causing your pain is wrong most of the time, unless you have perfectly normal discs at every level except for the one, or if you have like a tumor that's causing your pain, and you can see it on the MRI. The reality is that the only way to know where pain comes from is through a physical exam. So I would need to do a virtual exam. If you're interested, submit your MRI to our website, and we'll set up a telemedicine where I can do a Zoom call with you for about 10 minutes. I can answer your questions, and I can figure out where your pain's coming from. I'm able to do that with a telemedicine consult on Zoom. Go ahead and give them the free MRI review address.
Hold up.
All right, great. Laser. This is our last disc we're fixing. This is the L3-4. How are we doing, guys? Yeah, it is.
We have another question.
Sure, I'll take the questions.
This comes from Lizzie Henry once more on Facebook. And they follow-up question about the disc healing and not having another rupture. So what's left in the disc if the jelly is taken out to create the cushion and keep the vertebrae from collapsing onto each other?
What's left in the disc?
Yeah.
All right, so maybe they're not understanding.
Oh, yeah. I meant to. So what's left in the disc if the jelly is taken out?
Well, who's taking the jelly out?
I assume the surgeon?
No, we're not taking the jelly out. We're taking the jelly that's already out. The jelly that's still in the disc is what's left. We're not taking any jelly out from their disc. What you really should be asking is how much of the disc is the herniation? And the answer is about 5% of the disc. So we're only taking out the herniation, not the jelly in the disc. I think you're confused about what we're doing. We're not removing the jelly from the disc. We're removing the jelly that's herniated. Herniated means it's out of place. It's already been squeezed out. All right, is there another question?
No current questions, but we do have. Yes, from Lizzie Henry. She said, "Okay, thanks. So, how is this different from a discectomy?"
A discectomy?
Yes.
A discectomy, the surgeon's going to rip your muscles off your spine and kill your muscle. They're going to create scar tissue around your spine and nerves. They're going to drill holes in your lamina and bone. They're going to remove part of your facet joint, called a partial facetectomy. And they're going to remove your ligamentum flavum that holds your spine together at that segment. Then they're going to have to move your nerve root over. A discectomy is a barbaric old surgery that causes a lot of damage. Discectomy will cause you to need more surgery down the road, usually within a year or two. You'll probably need a fusion done after your discectomy. You don't have that with the Deuk laser disc repair. It's not even in the same ballpark. You can actually go to our YouTube channel under animations. There's a video there called microdiscectomy, which is what you're talking about. And it shows you how the surgeon has to remove bones and ligaments from your spine, as well as the facet joint, in order to get down to the disc. We're not doing any of that. Tremendous collateral damage with a microdiscectomy. But it's all under the skin. You can't see it. They hide it from you. I stopped doing microdiscectomies years ago because they're so destructive and damaging. All right, we're just about done with this disc. Then we're going to do a Deuk plasma rhizotomy, but we won't be streaming that. So if you have some more questions, this is the time to get them out. We're just about done with this patient's surgery. This is the most superficial part of their herniation and their tear. Grab her. There's a big piece of herniation there. Can't even get it all. Ah, that's better. Still some left. All right, take that. It's really hard to remove the herniation without the laser. It's actually impossible. So that's why the laser is so important. If you notice, I use the laser for about 95% of the surgery. I use the grabbers for about 5%. Most surgeons don't know how to use a laser, or they don't have one available to them. So when they talk about laser spine surgery, they really don't know what they're talking about because they've never done it. But you know, for normal open surgery, you don't need laser like microdiscectomy. You need drills and you need rongeurs. Those are tools that remove bone and ligaments. Since we're not removing bones and ligaments with the laser surgery, we don't need those kind of instruments. Let's go ahead and show our audience the difference between, say, a traditional surgery like a laminectomy or discectomy or fusion and the Deuk laser disc repair.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized